Good evening and welcome to Doctors on Call. If you have aching feet, knees, or hips, our program tonight will be of special interest to you. I'm Dr. Ruth Westra from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth, and I'm your host. And I'm pleased to welcome this evening's panelists, Dr. Samuel Harms, an orthopedic surgeon with Orthopaedic Associates of Duluth, Dr. David Ruta, an orthopedic surgeon with St. Luke's Orthopedics and Sports Medicine, and Dr. Joseph Signorelli, an orthopedic surgeon with Essentia Health, Duluth. It's time to call in those orthopedic questions locally at 218-788-2844 or toll free at 1-877-307-8762. Our telephone volunteers tonight include staff from the medical school, Katie Crassaway, Linda Liskowitz, and Amy Sipe. And now on to the discussion. So, Dr. Ruta, I see you have a foot in your hands.
Yes.
So perhaps since you have the model, you can explain just some basic anatomy of the foot and where common arthritic problems would occur in a foot.
Sure. So this is a right foot. I end up seeing a lot of people that have arthritis in the big toe, so-called hallux rigidus, and the midfoot. That may or may not be associated with collapse, a flat foot. If you were to push this down, you end up with somewhat of a flat foot. And then ankle arthritis is going to be this joint right here. And then the lower ankle joint is the subtalar joint, which is the side-to-side movement. Those are the most common forms of arthritis and by far the most of what I see.
Oh, thank you. So Dr. Harms, commonly we have problems at any age with sprains. What would be a common sprain of a foot?
The most common ankle sprain, I'm going to borrow your model,
Please
Dave,
do.
is a sprain of the outside ligaments of the ankle. Specifically, it's called the anterior talofibular ligament or the calcaneofibular ligament right here. And that happens when you step awkwardly on the side of your foot and your foot rolls in like this. And that's when you get the pain and swelling on the outside of your ankle.
Fantastic. Well, Dr. Signorelli, what would we do usually for arthritis before surgeries? Any things that we would commonly recommend?
Well, I think arthritis of many different joints of the body are kind of treated similarly. We try to look at a multimodal approach at how can we try to control symptoms and do what we can to avoid surgery whenever possible. A lot of times that includes anti-inflammatories, over-the-counter medications, attempts at weight loss, trying to strengthen all of the muscles that are around the joints. Occasionally we'll use injections and activity modification to avoid things that bother you.
Well, Dr. Ruta, just back about, we talk about knee replacements, we talk about hip replacements. How common is it for somebody to have an ankle replacement?
That's increasingly common. The previous generations of ankle replacement in decades past did not do well. And those have there have been significant efforts to redesign those. They're doing far better. There is a lot of research at this point to where they are pooled in so-called meta-analyses or systematic reviews, which is basically pooling data from many different papers to come to these very broad conclusions. And a lot of the recent data suggests that ankle replacement and ankle fusions have similar outcomes as far as pain relief. With ankle replacements, there is a little bit of a higher risk of reoperation. They do have a slightly better gait pattern, however. They walk a little bit better. And there are specific indications if an ankle replacement, because it moves, also tends to spare the nearby joint a little bit better. And so it's becoming increasingly common. It is a little bit different from hip and knee replacements in that there's more of a recovery before you're able to bear weight on it.
Dr. Harms, what about injections for problems with the feet? Would we consider doing something like that?
Yeah, injections can be in the line of non-operative management for arthritis of really any joint, ankle, knee, hip. The most common injection that people hear about is a cortisone injection, which is a powerful anti-inflammatory medication that we inject into the joint. And you can inject it right into the joint that has the severe arthritis that you believe is symptomatic. It's not something that we try to do over and over, as cortisone can have kind of negative effects on the cartilage or surrounding tissues and capsule of the joint, but certainly is a treatment option.
Good, we're starting to get questions, and that was one of the questions is how often can I get cortisone injections?
My policy and recommendation is not to get more than 2, maybe 3 a year. I don't know if these guys have any thoughts on that.
Yeah, I'd take a similar approach, roughly every 3 months, but something like 3 per year. And it depends a little bit for me on how subcutaneous the joint is. If you get cortisone in the skin, it can have a little bit of what we call fat atrophy, where the skin thins. And depending where you're getting it, like the heel, for instance, that can become an issue.
Dr. Signorelli, we're having more hip replacements, knee replacements, and now also more conversation about ankle replacements. And so there have been different approaches, and I think we've had some conversation about this in the past too, about anterior or posterior. Maybe talk about that a little bit.
Yeah, I think there are
hips.
different approaches or way to get into the hip joint for doing a replacement. I don't think it has a whole lot of bearing in terms of what we do when we're in the joint in terms of replacing it or which parts are used, but it can have some effect on the recovery process. So the anterior approach is one approach where you can get into the hip joint without cutting any muscle at all. It's an approach that goes between muscle groups, it goes between nerve groups. And so it has some advantage in the early recovery period in terms of having less pain and a quicker recovery. There's more information saying that a lot of that may be in the first 3 to 6 months. I think that's one thing that's important from a patient standpoint in terms of when can I get back to doing what I want to do. I think from a long-term standpoint, a lot of people that do an anterior approach and really believe in the benefits of an anterior approach, we see that you are able to get the components or the parts into the patient in the correct position, which can lead to increased longevity or how long that joint replacement lasts. Also has some benefit in terms of if you're not cutting the muscle, and the muscle is what holds the ball into the socket, there's a fair amount of evidence that suggests that the chance of the ball coming out or a dislocation is lower.
Nice, very helpful. Dr. Harms, caller asking about knees, and if you have more pain in your knee and are considering a problem, like what kind of exams would we do? Do we go right away to like MRIs, or is there something else that we would do to find out what the diagnosis is?
Yeah, the diagnosis of knee pain can be relatively simple, and oftentimes it's just a discussion with your doctor based on how long has your knee been hurting, did you injure it, where does your knee hurt? You can tell a lot just by those simple questions, and the knee is a relatively what we call subcutaneous joint, so where the problem is kind of on the side of the knee where it tends to hurt. And if you can't identify the problem by exam or by discussion, usually a simple x-ray will get you down the right road to identifying the problem. Doesn't always need to be an MRI or a fancy scan of any kind.
Helpful. So Dr. Ruta, a question from Superior asking about if exercise slows down bunions, or would that improve it at all?
To my knowledge, there has not been any reliable data that would suggest that exercise would slow the progression of a bunion. There is likewise moderate data. The data is back and forth on whether even flat feet are associated with bunion, and some people would say that exercise or strengthening of our calf can help support our arch a bit. None of that has been shown to be a very reliable intervention. More so avoidance of constrictive footwear and heels that place a lot of weight on your forefoot.
Thank you. Dr. Signorelli, a caller asking about stem cells. Stem cells for joint improvement. Does anybody want to take that, or do you have any?
Well, I think maybe we can all take a crack at that one, but I think it's an area of interest and an area that I think we all have some hope for in the future. It's to this point not something that's used on a regular basis in our practices today, but something that we see as some hope for the future. If we could find a way to prevent arthritis in the first place, or regenerate cartilage, is just one type of tissue in our body that really doesn't renew itself. If we could find a way to do that, that'd be great. If we could find a way to avoid arthritis and put us out of business, that would be great. I think it's something that's important that we continue to look into, and something that needs to be studied in the lab. But in terms of practical uses today, it's still in the infancy.
Yeah, I would agree with that. I think it's definitely still in the infancy stages. We're really not sure as far as the concentration of stem cells or other platelet-rich plasmas, another injection that you'll hear about. We're not sure the concentration that's effective for that yet. There's still early studies ongoing, but it's not something that's proven to be regenerate cartilage or reverse the process of arthritis, that's for sure.
And the concentrations thereof are variable. So just saying platelet-rich plasma doesn't necessarily define exactly what's within that injection. And so even that's not as well defined.
Oh, thank you.
And I think that's an area where patients can kind of, the more patients, the more knowledge they have, the more they can empower themselves with what information has some validity behind it is important. There are applications in orthopedics where it can be very helpful, and ones where it's definitely in the experimental stage, and I think the patient needs to know that ahead of time and know, is this a proven remedy or is this something that's not borne out yet?
Dr. Harms, there's a caller asking about nitrous oxide for severe pain. Any comments about that?
I don't have any experience with that, you guys?
Not in my practice.
No, and I think that's another perfect example of something that there may be some anecdotal information to say that that or other interventions are potentially helpful, but what we really rely on when we're treating our patients has to do with science and evidence, and if we look at a large population of patients and we use this intervention, can we expect a good result? And what is the expected good result? What's the likelihood of that happening? And what are the potential side effects?
Dr. Harms, a caller asking about SI joint pain.
Yeah.
And if the pain that kind of goes up and down, and if there's any recommendations besides cortisone injections.
The best thing for SI joint pain or SI joint dysfunction would probably be a physical therapy or stretching or strengthening program. So what it typically involves is stretching of the piriformis muscle, a muscle in the back of the hip, stretching your hamstring muscles in the back of your thigh, and also doing a good hip and core strengthening program.
Very helpful.
But it can oftentimes give you that pain either in your back or radiating up and down the leg. A lot of people refer to it as sciatica.
Sometimes hard to differentiate if it's your back or your hip that's causing the
That's
problem.
oftentimes the hardest problem is it your low back, is it the SI joint, or is it your hip joint causing these symptoms? And that can often take several visits and several different imaging studies and possibly a diagnostic injection of some sort to figure out.
Dr. Ruta, a caller from Superior asking about gout. So where would gout potentially show up in the foot, and if a diet, questions about the diet related to gout?
So gout is that, and a cousin of it is so-called pseudo-gout. Those are crystalline arthropathies, which basically means that little crystals deposit in the joint. Those are severely irritable to the joint, and so it elicits this inflammatory cascade where your immune system it reacts to those crystals, makes it extremely inflamed and painful. It is commonly in the big toe, and they give a term for that, podagra. And that's commonly where it initially manifests. There are definitely dietary associations with that. There are also some metabolic associations with that. Some people have a propensity to develop those types of crystal deposition conditions. I do think that especially if you've had that is an important conversation to have with your primary care physician about diet modification, and there are medications that help to shorten the inflammatory course, and then prevent further recurrence. And ultimately, if you have several recurrences, it can damage the joint. So it's something to pay attention to.
All right. Well, thank you. Dr. Signorelli, caller from Duluth, asking about a partial knee replacement about 2.5 years ago. Maybe talk about what's a partial knee replacement as well. But the question is how long it would last.
Sure, great question. So knee replacement, we think of the knee joint as kind of one entity, but we really break it down into 3 areas. There's the inside, the outside, and underneath the kneecap. So if a patient has significant arthritis in all 3 parts, then the usual treatment for that after we've exhausted non-operative options would be a total knee replacement. If someone has isolated arthritis in just one part of the knee, we can replace just that one part, and that's a partial knee replacement. There are both advantages and disadvantages to a partial replacement. With a partial replacement, there are some studies to show that patients state that it feels a little bit more like a natural knee. We're able to preserve more of the natural knee, and so as expected, there's more of a sense of a normal knee. It might be able to get back to a little bit higher level of activities, but that may come at a cost of longevity of the implant. So if you look at 10-year results after a partial knee versus a total knee, the longevity of both are about the same. Once you get out further than that, the total knee tends to last a little bit longer. So sometimes it comes down to a discussion of what are your goals? If your goal is to have the one knee that allows me to get closest to a normal function for certain activities that may still require cutting or pivoting or kind of high-level athletic activities, then a partial may be the best choice for that patient. If someone says, I want one surgery and I want it to last as long as possible, then it might be a total knee replacement.
Just to add to that, you can, just because you replace the part that has arthritis doesn't mean the rest of the knee behind the kneecap or on the outside of the knee can't develop arthritis, and so you can have progression of arthritis in other compartments, which can also be a source of pain down the road, which may require a conversion to a complete
exactly.
replacement. So,
Yeah. Are there any restrictions, Dr. Harms, on activities like after you would have a total knee done?
Yeah, I would say most of us don't like to see people doing high impact activities. I would say we don't like to recommend running or jogging as a source of aerobic conditioning. We like to see people continue with their strengthening and then pursue other forms of endurance exercise like swimming, cross-country skiing, going for hikes, doing things like that.
Dr. Ruta, a caller asking about plantar fasciitis.
Mm-hmm.
Maybe talk a little bit about that and potential things that we can do about that.
Sure.
Just a frustrating thing for a lot of people.
Yeah, that is. It's very frustrating. It is experienced by many people. It is typically heel pain. It's typically on the inside and the back of the heel. That's where it's most commonly felt. A lot of people will experience it with the first few steps out of bed in the morning, or after a period of inactivity. You sit down for a lunch break, or you go on a 2-hour drive and you wake up and you get up from that, and you'll have especially severe heel pain for the first few steps, and then it eases up thereafter, but then it comes back in the evening. That is largely a non-operative condition, and it is a slow-moving condition. And so the studies have shown that the best interventions are over-the-counter prefabricated orthotics and a diligent stretching program, both Achilles and plantar fascia. And you say, well, why is that? Why the Achilles? The Achilles tendon, which comes down muscle bellies, and then Achilles tendon goes to the back of your heel, and then the plantar fascia wraps around it, somewhat like our tendon does in the front of our kneecap, and comes down to the bottom of our foot. And so if you have a very tight Achilles, you end up with bottom of the heel pain as well. And so there are some cortisone injections that can be done. They've been shown to have temporary benefit usually. Long term, there's no difference between those who did and did not receive an injection. There are some small but present side effects to those injections, like a plantar fascia rupture or fat pad atrophy. And so it takes a bit of diligence and patience with that, usually diligent stretching and some orthotic supports.
Yeah, it can take several months or even a year or more
Yes.
before it fully resolves. It's very painful.
It's sort of like the cup that sort of fits in a shoe type of apparatus too.
That's helpful, yes, and also an arch support, an orthotic that has an arch that if you set on a table and push on it, it will resist you. If your weight's going into the arch, less of it goes into your heel.
Thank you. So let's ask about total hip replacements. Dr. Signorelli, how good are joints these days? That's what a caller is asking, the ones that we're utilizing.
Yeah, so I think the field of arthroplasty or joint replacement tends to improve, but in small increments as time goes on. So I think we're really lucky in the infancy of joint replacement to have pretty darn good results right off the bat, and it's always a battle of trying to improve what we're doing without taking a step backwards. And I think, unfortunately, we've shown in our field that if we try to get too innovative, sometimes we'll solve one problem and create a new problem. And so that's the challenge, is try to increase the longevity and make them last longer and make patients have less pain and more function while at the same time not cause new problems. And so I think because of that, a lot of us are favoring implants and techniques that have, again, evidence behind them. And with that, most large scale registries, which look at the results of all the, say, hip replacements that are done in a country over a long period of time, show that they tend to fail at about 0.5% per year. So if you go 10 years out, 95% of people are doing fine. 20 years out, 90%. And even up to 30 years, we're starting to get some information. The hard thing is trying to look at 30-year results. That's implants that by definition were put in 30 years ago, and manufacturing and materials have changed. So we're kind of comparing results from a long time ago to what's being used now.
Mm-hmm. And what are the joint replacements made out of most commonly, Dr. Harms?
Most commonly, the hip replacements are made out of titanium or titanium alloy, a mixture of metals, and then the bearing surface itself is the important part, and that's typically either a metal ball in a plastic socket or a ceramic ball in a plastic socket. But that's the smooth barium surface that is probably the most important and probably is what wears out long term and determines the length of viability of our implants.
I think in the past we've also had concerns about viability with people that are a little bit more heavy set getting joint replacements. Is there anything to warrant being more ideal body weight before you have a joint replacement?
Oh, definitely. It's shown that your risk of a complication around joint replacement surgery, if your body mass index is more than 40 or someone who would be considered obese, is probably double or more that of the general person. And so we do everything around surgery to improve their health, whether it's control diabetes, control high blood pressure, and optimize their health. And that would include a weight loss program to try to mitigate those risk factors.
Yeah, I completely agree with all that, and I'd say that it has to be a team approach between the patient and the physician to say, how can we get through this safely, and how can we again have the benefits of the surgery without the side effects. And so I just try to get across patients that it's like taking the biggest test in your life, and if you're going to take a big test, you have to be prepared. And so what can you do to be as healthy as possible going into surgery? And I think that's something where a patient can take some of that information and they can be informed, and again, they can be kind of a champion for their own health.
I think one of our biggest concerns around any kind of joint replacement is definitely infection. That's our biggest concerns, and I don't think patients understand how big of a problem that is. It's not simple taking pill antibiotics. It's usually another surgery or 2 or 3 and long-term IV antibiotics, and oftentimes it's hard to eradicate.
There was a recent study that came out that showed that the 5-year survival, or how many people are alive 5 years after an infection and joint replacement, is worse than 4 out of the 5 most common cancers in the United States. So again, to echo Dr. Harms, it cannot be understated how catastrophic a problem it is. And so I think absolutely every effort to prevent infection is so much more beneficial than treating an infection once it's occurred.
Is there any reason, Dr. Ruta, that somebody would not be recommended to have a joint replacement?
Like Dr. Harms and Dr. Signorelli were discussing, there are certain what we call relative contraindications where there are things that have been shown to dramatically increase your risk of failure, such as a notably elevated body mass index or a very poorly controlled diabetes. And then there are absolute contraindications like a current infection or something that would put you at risk for seeding your joint. And like Dr. Harms said, if that occurs, that's a substantial problem. And so there are a whole set of relative contraindications and absolute contraindications, and that's always part of the decision-making process that goes into an arthroplasty.
I think a lot of times patients will say, well, you know what, my hip hurts so bad, there's no way it could be any worse. And the thing that we really need to get across to patients is no matter how bad it is, the only thing any surgeon can guarantee you is that we can make it worse. And so we do everything we can to make patients better, but it always has to be a discussion, again, of what can we do to have you as prepared and as healthy and best prepared for the surgery.
Well, Dr. Harms, like during the recuperation time after having a replacement, what types of activities are done to help a patient get stronger, feel better faster?
I would say with our hip replacements, especially using some of these muscle sparing approaches that Dr. Signorelli talked about, is there probably is not a lot of rehab for hip replacements. Just some simple leg strengthening exercises they teach in the hospital. But knee replacement's a different story. That usually takes kind of some more intense physical therapy, at least in the first 4 to 6 weeks, to get your range of motion or your mobility back, and then start to get on a pathway to gain your strength. And that does take more time, but if you don't get your range of motion back in the first 4 to 6 weeks, it can be a stiff joint, a painful joint, and in essence, we've probably made you worse, and that's not what any of us want.
Yep.
And most of the time, right after the surgery, like the day after, people are moving. Rapidly.
I think that rehab has shifted in the focus, and there's really an emphasis now that the earlier you get up, the earlier you get after, the better patients do. So it's really a mandate that we get you up moving the day of surgery. I think the whole recuperation process has been shortened. It's much more common now to actually have a joint replacement and possibly go home the same day. So it's trying to figure out, to echo Dr. Harms' point, looking at different phases. You have to look at what do we need to do, say from 0 to 2 weeks, and 2 weeks to 6 weeks, and 6 weeks and on. And so we really try to provide detailed information, exactly what you need to do, what you need to look out for, and how to help yourself recover at home after surgery.
that's kind of where joint replacement is going, is to more of an outpatient procedure now. It's not, you're going to have your surgery and go home the same day or the next day. You're not going to stay in the hospital for 3 to 5 days like it was pretty common 10 years ago.
Right.
That's an important distinction with ankle arthritis surgery. That is very commonly an outpatient procedure, it typically is. And so you do go home the same day, but it's not the same recovery. Whether it be a fusion, an arthrodesis, or a replacement, there's several weeks of non-weight bearing. And so patients have to take that into consideration when you're having a discussion about undergoing an ankle replacement or an ankle fusion for ankle arthritis. The recovery thereafter and the rehabilitation is quite a bit different than hip and knee replacements.
Very helpful. Any last words? That went really fast, so we're almost out of time. Last words of advice prior to surgeries?
I think if we give anybody 2 pieces of advice, have a healthy diet and find a way to stay active. If you do those 2 things, you're going to set yourself up to try to avoid needing our services.
Thank you, thank you. So I want to thank our panelists, Dr. Samuel Harms, Dr. David Ruta, and Dr. Joseph Signorelli, and our telephone volunteers, Katie Krassaway, Linda Liskowitz, and Amy Sipe. Please join Dr. Alan Johns on January 18th for our next program on lung problems, when his panelists will be Dr. Mary Owen, Dr. Eric Swanson, and Dr. Paul Zimmerman. Thank you for watching. Good night.